Hi, everyone. Welcome to HerniaTalk Live. We're entering the summer time right now, and I'm super excited to host another session of HerniaTalk Live Q&A with you. My name is Dr. Shirin Towfigh. You know many of me as the Hernia Doc. I am a hernia and laparoscopic surgery specialist. Thank you for following me on Twitter and Instagram at Hernia Doc. Many of you are joining me live on Facebook at Dr. Towfigh. And as always, this session will be hosted on my YouTube channel for you to review and subscribe and watch some more. So let's do this today. I decided the topic for this week should be on expert opinions or second opinions and surgery. The reason why I asked that, why I chose that, is because I've seen a couple of patients lately and they've had 2, 3, sometimes 4 operations by the same surgeon, or they were told something by one surgeon, and basically for the past, like today, patient today, since 2014, he's been suffering from pain, and the doctors have told him there's nothing to do, so he kind of just went forward with no hope. And then he reached out to me, but now it's 2021, so that's a lot of years to just follow with pain, and it becomes chronic pain, and some people can get really sick from it, and it affects your quality of life. I see people who lose their jobs because of chronic pain. They're depressed, suicidal. People get divorced, their children leave them. I mean, it's a pretty serious problem, and I don't take chronic pain serious. I take chronic pain very, very seriously. I don't think people should be suffering. And for example, this one patient, actually the second patient that I saw today, made a comment, or a comment was made to that patient that, oh, don't ever do this surgery. You're going to be so sick. It's a very lethal operation. I've had people been told that they shouldn't have their mesh removed because they can lose their leg. It can affect their erectile function. They may get their testicle removed. Like, all these things, completely not true. And yet it offers so much anxiety and stress to the patient, so they end up losing hope and not moving forward with a potentially life-altering surgery, or life-altering meaning that it will improve the quality of life. So hi to those that are logging in right now. Thank you very much for joining me. And I thought I'd try and dispel some myths that we hear among patients that are concerned about having a second opinion, because listen, I'm often the second opinion surgeon. I highly encourage my patients to go to a surgeon local to them that I can work with. In fact, I've told them to go see other doctors if they want another opinion, just to put them at ease before they make a big decision to undergo surgery. So based on that, I feel that we need to kind of get something straight. First of all, let's review, why do you need a second opinion prior to hernia surgery? My personal shtick is, unless you're having emergency surgery and you need to make a life-saving decision, if you're having elective surgery, it can be anything from a bunion surgery to a hernia surgery to a revisional operation or a cancer surgery. Whatever the surgery is, I think you should get a second opinion. That's just my 2 cents. I mean, we're all doctors, me and my friends and I, and even when we know this field that we're talking about and we go to one surgeon, let's say we need surgery, we go to a surgeon, we still go for a second opinion just to make sure that a second eye is looking at the problem in a different way sometimes. Some people will have a different take on things. They will provide you with a less invasive option for the same problem. I've had patients that go to one doctor who wants to cut all the nerves, and the other one comes to me and I say, you don't even have a nerve problem. Let's not touch the nerves. So It's just a different take. In fact, maybe you don't even do surgery. You need just injections. So every person will have a different opinion. And I highly encourage for elective surgery to get a second opinion for anything. It could be breast surgery. It could be like, gynecologic surgery, your prostate removal. Do I need my prostate removed? One surgeon says yes. One surgeon says no. Get more than one opinion, and then you can at least see if they both match, great. If they don't match, then why is that and how can that improve you? So that's kind of my shtick. I'm not a big fan of surgery in general. I think if you can get the same outcome without surgery, that's a good option. And getting a second opinion is part of that kind of very conservative attitude prior to going to surgery. So that's my thing. Does insurance, that's another question I was asked. Does insurance pay for second opinions? Insurance typically allows for consultations. That could be first, second, or third consultations. So, or fourth or fifth or whatever. The term second opinion is actually an old term. There used to be a billing code where you code for a second opinion doctor, but not really the treating doctor, and it just paid differently. As far as I know, that's completely out the door. Medicare put a kibosh on that. So any doctor's visit is treated the same, whether it's for a first opinion, second opinion, et cetera. So don't worry about it not being covered by your insurance, assuming all other things are correct. So that was my shtick on third opinions. Yes, there is such thing as a third opinion. Now, sometimes I see patients that I'm like the 10th doctor they're talking to. And I don't want to call it doctor shopping because often it's because of a rare problem or a difficult problem or anxiety over a situation, and they're trying to understand their problem, not so much doctor shop. So doctor shopping implies I want one specific type of procedure, and I'm going to find the doctor that will agree to do that one procedure. So for example, it'll be, let's say, an incisional hernia in a patient on steroids with ulcerative colitis, and they don't want to have mesh in them. And they're adamant that they don't want to have mesh in them. So they will go from doctor to doctor, and every doctor will say, you need mesh, you need mesh, you need mesh. And they won't stop looking for a doctor until they find a doctor says, we can do it without mesh. And then they will go forward with that. So that to me is doctor shopping, where you're not necessarily following the recommendation, but you're trying to find someone to work outside the box, but not in a good way. The alternative is trying to get an understanding of what's going on with you in terms of your surgery and your diagnosis, and you just haven't found the one doctor that gives you the full shebang, like nice personality, skilled surgeon, knowledgeable physician, good bedside manner, office that, responds, like, to try and find, I think I provide the full shebang, to be honest. I think we have an amazing office and team, and I'm a huge advocate of fighting for patients' outcome, and I'm open-minded, but at the same time, I will not do something that is outside of what is appropriate for a patient. So I would not compromise a patient's care because a patient wants a certain thing to be done. I don't agree with that. So there are patients that go from doctor to doctor and never really decide on what they want to do. And sometimes that's really because they don't really want surgery, and instead are kind of just information gathering, which tends to add to more anxiety, but there's never like a cure to the problem. So I prefer if a patient commits to a surgeon that they trust and then moves forward with a plan of care, because spending 5 years trying to find a doctor when you're suffering during this whole time, I don't think is in the best interest of the patient. Okay, the other question that I get asked is, I don't want my doctor to know, or will my doctor know that I saw you? Or got a second opinion, or they're very concerned that somehow our ego or our personality or something will be affected negatively, like we would take it personally if you see a second opinion surgeon. I do not. I encourage it, and I think that you should not fear like retribution, or that your surgeon will like look at you differently if you went and got second opinion. I don't agree with that. But as I've probably said before, we're all human. We just went to medical school and did surgical residency and chose to do hernia surgery, but we're still human. And so we still have hiccups, and there will be doctors that will take it personally if you go get a second opinion. That's just the way any human may react. That should not prevent you from doing what's in your best interest. That's the way I think about it. What's a question I just saw on Facebook Live? It says, depending on the specific situation, can some hernias be repaired without mesh? Absolutely. Absolutely. There are a lot of situations where hernias can be repaired without mesh. It's a give and take. So, for example, the patient that I presented, ulcerative colitis, on prednisone, multiple hernias have already occurred, pushes to empty his J pouch. That patient is not a candidate for non-mesh repair. Now, someone may offer it, but I think it would be the wrong decision. Can it be repaired without mesh? Like physically, can I do it? Yes. Will it pop open in a couple months and he'll need an even bigger hernia repair? About 80% chance, yes, maybe higher. So that's why we don't do that. If you had an 80% chance of getting in a car crash when you go out driving, most people would choose not to drive. But it's always a risk-benefit ratio. All right, also, what's your opinion on Shouldice? I'm a fan of the Shouldice. So the Shouldice hernia repair is a tissue-based hernia repair for inguinal hernias, so hernias in the groin. It is for inguinal hernias, direct or indirect. It is not a repair for femoral hernias, even though there is a Shouldice version of the femoral hernia repair. It is the best studied tissue repair, and though it's not the oldest, but it's a pretty old type of repair. And there are other tissue repairs, Bassini, McVay, those are both types of repairs. There's a Nihus Condon repair. Anyway, I think it's a great repair. It's not for everyone. Most surgeons that are trained today are not trained to do the Shouldice repair, but as more and more of us are interested in hernia surgery and train in hernia surgery, and like the residents that I train, they all get exposed to getting Shouldice hernia repair done. All right. Is the general rule of thumb to leave a small inguinal hernia alone unless it becomes too painful? Will every hernia grow larger over time? Okay. So I told you we have a private group of surgeons that are international that talk about hernias all day. It's like constant, like talking about hernias and asking questions and so on. So this question was posed actually recently saying, all right, what do you guys do if you have a patient that has no symptoms or what we call minimally symptomatic and has a groin hernia or an inguinal hernia? What do you do? And I presented my evidence-based way of interpreting how to do things. I'm very conservative. I do offer watchful waiting for as many people that are good candidates for it. I always have that as a discussion. If you have no symptoms, I don't feel like, how am I going to make you better with surgery if you already have no pain? Now, if the quality of life is better with not having a bulge, that would be one alternative, but I may also induce pain. So there's that discussion that I have. Other surgeons say, no, every hernia will get bigger, and a percentage of patients, those small, will have their hernia emergency. I can't tell you, Mr. Patient or Ms. Patient, that you won't be that one person. So why take the risk? Let's just fix your hernia repair. So to me, that's a different interpretation of the data. I don't agree with it because that implies that everyone with a hernia, regardless of symptoms, should get repaired. To me, that's a very old way of thinking about things, and we have very good prospective randomized trials that show it's perfectly safe not to operate on patients. So yes, hernias will get bigger over time, but that may be 20 years. A small inguinal hernia in a female will probably never get bigger. A large hernia in a male may get bigger. So the data is out there to support watchful waiting as a safe manner. We just reviewed the data, so up to 2/3 of patients over a span of 5+ years will choose to have surgery, even if their surgeon initially said, let's just watch this. Because they just get tired of the bulge, they get tired of dealing with it. It may affect their quality of life. The bulge may have gotten bigger over time. So all of those things are right. Okay. Am I trained in Shouldice? Yes. So I do perform the Shouldice hernia repair. I have been to the Shouldice clinic. It's a hospital clinic. Really great people there. They're very dedicated to their craft. I do offer the Shouldice hernia technique for inguinal hernias to anyone that's a good candidate for tissue repair. All right, some patients who've had reaction to mesh or implant or even sutures might seek multiple opinions because of the fear of another surgery, which can potentially cause a similar reaction. That's true. The thought process is live with live with the pain now or live completely disabled. How do you help these patients navigate their healing journey? Well, obviously, the big deal is I'm not the one that has to live with the hernia, so I have to somehow do my best to give you somewhat of a picture of what the expectation is. So for example, some people think that they will get maimed and disabled for life. That's almost never true. Almost never. And by almost never, I say like more than 99% not true. We surgeons will never offer you an operation where you will be disabled. Now, do complications occur? Yes. But most of the time, complications are in the 1% to 5% range. We don't usually like to do repairs that imply really high rates of complications. So the risk is there, as with any surgery, but it needs to be put into perspective. So that's one thing. The second is we just don't know enough. Mesh reactions, which is this question, is an enigma. Some people get it, some people don't. Some people are at risk for it, some people aren't. We have no idea how to accurately predict. Like if I tell you your blood sugar is 200, which is very high, by the way, I can reliably predict you have diabetes, but I can't do that with mesh. I can't say that you have 100% or even a 50% chance of reacting to mesh. I can say maybe you have a higher risk. Even that, what does that mean, higher risk? We don't really know. So that is an evolving study. Many of us are interested in it. I'm very interested in it. We're using our best judgment to guide people based on our experience, and hopefully over time, as our experience increases, we have more data to support what we offer patients. So yes, something rare, like a terrible mesh reaction, and by rare, I mean that almost no surgeon sees it on a regular basis. And percentage-wise, we feel it's very small, even though it's a large number of people. Yeah, those are difficult. Those are hard. And those are definitely patients that should see multiple specialists, even though there aren't that many of us to begin with. Okay, I'm interested in seeing someone that is trained in that technique or does a tissue repair. Yeah, so I mean, the Shouldice clinic itself is the best place. They're all trained there and do it for a living. Canada is still closed, I believe, to US travel. But once that opens, if you want a real Shouldice repair, you just go to the Shouldice clinic. Short of that, there are many of us around the nation that do offer the Shouldice repair. You just have to call and ask. There's no database that shares that information. How much muscle is removed when abdominal mesh is removed? What are the chances of absorbable sutures holding up with application? So virtually no muscle is removed. A very, 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 very small amount of the muscle is stuck to the mesh. But when we remove mesh, we really shave it off. It's like peeling a cucumber. You can do a really good job of peeling the cucumber. So all you do is take the skin off and leave all the cucumber behind. So that's definitely possible. What is the chance of absorbable sutures holding up with application? Depends on the suture. There's slowly absorbing suture that do better than the rapidly absorbing suture, number one. And number two, we don't know. As far as we do know, applications do best with permanent suture. So you're kind of playing with the odds of recurrence if you're relying on absorbable suture. Again, 100% is not the answer, or 0%. It's somewhere between 0 and 100% of patients will have a recurrence when using absorbable suture for hernias. Oh, fantastic answer. Y'all welcome. I've had mine for 10 to possibly 15 years. Got it looked at 8 years. Oh, your hernia, I assume. I've had my hernia for about 10 to 15 years. I got it looked at 8 years ago, and the doctor told me to leave it alone for a while. Recently, it started popping out more, feeling uncomfortable in certain positions. I lift weights regularly, and I'm worried about tearing or popping out and it becoming an emergency. Okay, so here's the data. There's 2 prospective randomized trials, one in the US, one in the United Kingdom. They both looked at males, and I believe you're a male. Both looked at males, one all males, the other one adult males, the other one males, I think age 50 or 50, I think 55 or older. And they took the men with hernias that were either asymptomatic, so no symptoms, or minimally symptomatic, so a little twinge here and there, but didn't really affect their quality of life. And they randomized them to 2 arms. One arm of the study, you got your surgery. The other arm, you didn't get surgery, and they watched you for up to 10 years. And they looked to see what happens. The reality is nothing much happened. The risk of something bad happening in one study was quoted at 0.18% per year. Of course, it's not 0, but that is a low percentage. So if you don't want to have hernia surgery, feel confident that that decision is safe if you have no symptoms. Do the hernias get bigger? Yes. We don't know per patient how fast that will occur. Will the hernia become symptomatic? So you move from having no symptoms to having symptoms? Possibly. And again, we don't know the percentage of that. In these studies, up to 2/3 of them had worsening pain up to around 10 years. So to the point where they wanted to have surgery. But, every patient's different. Just know that watchful waiting doesn't mean that you're committed to it for your whole life. You can reassess it at any time. In terms of emergencies, it's 0.18% risk per year. Low risk. So it's 0.18. It's about 0.2 is 1/5, so like 1/7 of a percentage. Okay. I have an incisional hernia from a C-section. Is it possible to have it repaired without mesh? Incisional hernias from any operation should be repaired with mesh. And the reason for that is we have a great study out of the Netherlands that showed that if you choose to repair incisional hernias without mesh, there's a minimum 50% recurrence rate. Now, they were studying like real hernias, like big hernias. They were not studying C-section scars or small hernias. So if I have a patient with a small hernia recurrence, I don't put mesh in them. The chance of that is going to be much less than 50%, most likely. C-sections also, if you have a small scar, or small hernia, you could consider non-mesh. But in general, the answer is yes, you should use mesh. And mesh is highly variable. There's tons of different meshes out there. I'm all about being conservative and weighing the risks to benefits, so I'm on the same page as you. Thank you. Also, thank you for answering these questions. You're welcome. Yeah, thanks. I don't want to say we got into a fight, but we got into like some heated debate on these like surgeon interactions, because some surgeons feel so strongly that a surgeon, like if a patient comes to your office, by definition, that means they're asking for help about their hernia, and your help as a surgeon should be to operate. And I disagree. I feel like they're there to ask for advice, and the impetus to operate should not be because a patient walked through your door. So I don't know. I would love to hear what you guys think, because I get plenty of patients that I say, oh no, you can totally wait on this and go do your exercise and be as active as you wish to be. And they're like, oh, that was the best news ever. I was stressing and I thought you told me I have to have surgery, and I couldn't sleep last night, and I was hoping you would be able to say that I didn't need surgery. And so, that's my experience. But I'd love to know what you guys think, because at the end of the day, it doesn't matter what I think or the surgeons think, it's what you guys think. You guys with the hernias. I don't have a hernia yet, but sometimes I feel a little twinging, so I hope I don't have I hope I don't have a hernia. What do you suggest for sutures? Have you heard of Monomax? Monomax, I haven't heard of. I'd have to look to see what it's made of. But the typical sutures I use is Prolene suture or Ethibond. It's a polypropylene or a polyester-based suture. Sometimes for people that have reactions to that, I use nylon. Neurolon is another type of like braided nylon. So there are a lot of options. And then PDS or Maxon are the sutures that are used for the long-term absorbable. Sometimes patients with 5 layers of inguinal hernia mesh and coils. I don't know what they're saying. Sometimes patient with 5 layers of inguinal hernia mesh and coils, weak, broke, tired, dying from this. I feel mesh removal is super risky. Since after my many researches and all the hernia groups, I can't find one male that has done well with this. I also realize I need to play Russian roulette with surgery, then deal with the outcome. Yes, of course I have issues mentally from all this. How are long-term patients with recurrence issues over and over supposed to get help? I have never smoked, drink, etc. Okay, so 80% of what I do is revisional, and much of that involves mesh removal. And my patients do not die. They do not have bad outcomes. I mean, there are a handful of patients that I'm still working on that we're trying to get to be cured, but in general, they all do pretty well. I can't say I have a 100% success rate. That would be not true. Every surgeon who operates for sure has their own complications, but I don't want to discount the operations I do. It can be risky and it can be complex, but you have to get to a point where you want to have surgery and improve your quality of life. And when you get there, you should look at finding a surgeon that does that for a living. And then once you do, get a second opinion too, to make sure that all your questions are answered and that you pick the right surgeon for yourself. Never had a positive test of any kind saying I have a hernia, but I always do feel like Groundhog's Day. Yeah, if you've never had a study that shows you have a hernia, not sure why you have 5 layers of mesh in you. So I'd have to review your, that doesn't make any sense. Thank you for doing this. Don't blackball me for being honest. I do not blackball anyone. In fact, I don't even know if I block anyone. I don't think I do. I don't like to do that. I'm sure I've been blocked by many people though. True fact. I was told by one removal specialist in Florida that he could remove all of my mesh, but I would have the original hernias, which meant misdiagnosed for 3 years by 3 surgeons. Okay, so that is true. most likely your hernias will recur if the mesh is removed and you do nothing else. Sometimes there's scar tissue, but scar tissue is weak, and so you'll get a hernia eventually. But that's where the planning occurs. You try and plan, okay, I'm going to take out this, and then, okay, fine, I'm going to take out the mesh. That part I can do. Now let's discuss, what do I do once the mesh is out? How do you want me to repair it? And the options are A, B, and C, or just A, who knows? Monomax is P4HB. Okay, so Monomax is basically Phasix mesh, but the suture. In fact, let me rephrase this. The suture was originally used, the Monomax, in Europe, and then a company took that suture and made mesh out of it. So the suture, I believe, has an 18-month lifespan, which is a very slowly absorbing suture. The next one down is about 8 months. But as with all absorbable sutures, there's a limit as to their efficacy for hernia surgery, and every patient is different. Let me just tell you, in my experience, Phasix has a significant inflammatory component to it, and patients have reacted to it more than like a biologic, for example, number one. And we know from the Phasix mesh studies, after 3 years, there's about almost a 50% recurrence rate with that mesh. So it is definitely something to look at. So if the mesh lasts for 18 months and you look at it at 3 years, all those people that recurred after the mesh got absorbed, or many of them did. So that's kind of, what happens. All right, next question. I respect surgeons who suggest you consider waiting. We had one surgeon insist he could do my husband's ventral hernia repair robotically. 2 other surgeons said no to robotic, and only one was willing to consider open repair. I mean, the question is, who was right? Who was right? I mean, a robotic repair, if I had a choice between robotic and open, I would definitely go for robotic if all things were equal, because less scars, less scarring, less incisional hernia pain, less surgical site infection rate, better long-term results often. But there are situations where open is better, like if you have a lot of loose skin, or you have some kind of weakness in the area, you can tighten it up or something. So I don't want to discount the idea of robotic surgery for hernias. They're actually really great options robotically. That's kind of my 2 cents about that. All right, next question. I asked for a second opinion, and now I'm even more confused. Help. This is exactly what I think you mentioned. So you went to a surgeon, one said robotic, one said no robotic, and the one said open. And so now what do you do? So often it comes down to, number one, really having your questions written down to query why a surgeon offers one option versus the other. For example, is the open hernia surgery surgeon recommending open because they don't even do robotic? Or vice versa? Does the robotic surgeon recommend robotic because they don't know how to do it open? Is a mesh repair offered because they don't know how to do tissue repair, and vice versa? Those are questions that you need to ask. Why are they specifically recommending what they're recommending? If they say, well, that's how I do it, I would run away, because you don't want a surgeon that does the same operation on every patient. You want it tailored. And sometimes you need more than one opinion. But in general, if you pick and choose the right surgeons, then go for it. My other point also is, don't pit a surgeon against the other surgeon. We are all individual people and have our own ideas of how to do things and what works best in our hands. There may be a surgeon that does a great open surgery and a horrible laparoscopic surgery, do not force that surgeon to do laparoscopic surgery because you'll have a complication. And vice versa. They may be like, yeah, I mean, I can do it if you want, but I usually do laparoscopic. Yeah, don't force that surgeon to do your tissue repair, for example. So that's one comment. The second comment that I want to make is that if you're going to two surgeons for a second opinion, go to two experts. Don't go, or let's do this. Let's say you go to a community doctor that's near you, and you're like, you know what, I should invest in a surgical consult with an expert. Then you go see a surgeon who's an expert, and they say the same thing. Great. Then maybe you can stay local and have your surgeon do it, or you can choose to travel and go to the person further away who has more expertise, but at least the two kind of have the same recommendation. The flip side is you go to one surgeon who does everything, and hernias are one of them, and they don't really care about hernias, and they say they'll do it one way. And then you go to another surgeon that only does hernia surgery, and they say do another way. Those are not equal recommendations. You can't say, well, why the other surgeons say, I mean, you can say why the other surgeons say that, but just understand that you're kind of comparing two different surgical experts. And so if you don't you may need a tiebreaker with another surgical expert. I don't want to confuse this too much for you all, but my point is do your research not on what you think you should do, like online, but also with your surgeon. I'll give you a good example. I had a patient, today? No, it's today. Wow, these are all today's examples. I had a patient today who said, I want the Diastasis. Okay, so he's got bilateral inguinal hernias and they're not small. And it's like, I've done my research, I want to do the Diastasis. All right, well, why? Because I'm not a fan of the Diastasis technique and I have my reasons. And he's like, well, I just read and everyone says Diastasis is great. Well, that's not true. Not everyone says Diastasis is great. And there's very little data to support Diastasis compared to other tissue repairs in terms of their long-term outcomes. And, I gave him my 2 cents about the Diastasis. Oh, he said, okay, well, that's great information. Like, I didn't know that. I didn't read that. You can kind of fall into a rabbit hole when you do online research. And, I was able to kind of open his eyes as to like why we do one technique versus another, why he would be better with one technique versus another, and so on. And so I also kind of gave him the data for chronic pain with open tissue repair, with open mesh repair, with laparoscopic mesh repair, and so on. And yes, the Shouldice is one of several open inguinal hernia techniques without mesh. Yeah. So I hope this is like clarifying. I don't want to confuse you guys anymore, but it's one of those things where it really bugs me when people are misled, and because of them being misled and trusting one doctor or being told it's all in their head, they just believe it, and then years go by. I'll give you another example. I had a lady, I think I told you this story before. I think I told you the story because it really affected me a lot. She's a lady, I think she was in her 70s for 21 years, and that's my record so far. For 21 years, she's had chronic pelvic pain. Her son brought her in, lovely lady. She walks with a limp. She's uncomfortable. She would like to be more active at home. She can't be. She used to belong to a social club. She can't be. Sitting hurts, bending hurts, all these things. I'm like, you have a hernia. What? I have a hernia? Yeah, I've had this for 21 years. You're telling me I have a hernia? Yes, you have a hernia. Here's the imaging. Here's the study. Here's where it is. I'm going to show you where the hernia is. For 21 years, she was just told it's all in your head. It's chronic pelvic pain. Let's take out your uterus. She took out her uterus. Let's take out your ovaries. Took out her ovaries. Maybe it's your gallbladder. She had her gallbladder taken out. Maybe it's your appendix. Everyone was dancing around the diagnosis. Anyway, I fixed her hernias and I saw her after surgery, cured, like brand new person. And the son started crying. And it was because he had forgotten what it was to see his mom walk without a limp. I just get emotional every single time I tell this story. He does not remember what it was like with his mom to walk without a limp. Because now that the hernia is fixed, she's walking normally without a limp. For 21 years, she was told it was in her head and there's nothing to do, and everything that can be done has been done. So it really pisses me off when doctors or people tell each other, I see it on the forums a lot, don't do it, you're going to die. I mean, my patients don't die. Most of us who are hernia experts don't have patients that die. It's not considered a life-threatening problem. And we're there to improve quality of life. Which procedure do you think has the absolute least chance of injury or complication to occur? Open or laparoscopic? I was watching a lecture from a doctor about the numbers, and he said open is about 1 in 1,000, and laparoscopic is about 6 in 1,000. Of course, it's highly dependent on the skill. Yes, it's completely dependent on the skill. Just like driving, like what's the safest car to drive in? What car has the least car accidents? It's really the driver. So, you know, a professional driver or a terrible driver, someone who just learned driving, they'll have different traffic accident. Or like, where are you driving, in the freeway or in the streets? So in general, if done by someone who does this well, so if you're an expert open and you're doing open surgery, or if you're an expert in laparoscopic, you're doing laparoscopic surgery, they're pretty much equal. Laparoscopic is slightly better. So the chronic pain rate is slightly better and lower with laparoscopy than with open. That's if done by experts. So expert laparoscopic surgeon versus an expert open surgeon. If you take all laparoscopic surgeons and all open surgeons, not experts, laparoscopic is definitely better. And it has much better numbers in terms of reduced chronic pain and reduced risk of recurrence. However, there have been serious injury reports with laparoscopy, bowel injury, vessel injury. Knock on wood, I've never seen it, but I have read about it. It's not common, but it does get highlighted in many of the literature. So that's kind of the study, what I think. I'm glad you guys think this is good information. It's kind of one of those topics that I thought we should definitely review because no one ever discusses it. How do I know which surgeon to choose once I get a second opinion? Yeah, we kind of discussed this. I think you should go for the surgeon that you feel closest to, because if you have a question or if you have a complication, you need to be able to reach the doctor, not get ghosted by the doctor. I see this new term, being ghosted. I see that being used now by patients. My doctor ghosted me, and that's horrible. But some doctors may be overwhelmed with their job, or just personally feel like they don't like interacting with patients who have complications, and others are totally okay with like addressing things head on. So my personal bent is I always choose a doctor who has good bedside manner and is approachable and reachable, and will address a complication and be there for the patient. I think that's a very important trait. That said, they also have to be skilled. But if they were equally skilled, or one person's like more famous, I would still choose the one with the better kind of bedside manner. I think that goes a long way. It really does. Okie doke. Thanks for watching, you guys. A surgeon who seemed very confident gave the option to do robotic with synthetic mesh or open with biologic mesh. Why would mesh type determine if open or robotic? Yeah, that's ridiculous. No reason. You know, all surgeons are confident, by the way. There's a joke where we say sometimes surgeons are sometimes wrong, but never in doubt. You're kind of trained. It's like very military. Surgical training is very military type. And yeah, confidence can exude, but the skill has to be there to back it up. For people who have mesh reaction, what is the suture you choose to use most? That's a good question. I tend to use nylon or short-acting, absorbable PDS or Maxon suture. I've noticed that tends to give the least amount of reaction, but it is not the suture of choice for the typical patient. Solid answer, thank you. Okay. You guys are doing great. Time is flying by too. I like my first opinion surgeon, but my second opinion surgeon is more skilled. Which one do I choose? I kind of answered that already, but the take-home message is you need to be comfortable with your surgeon. And a skilled surgeon that won't address your needs, I don't think is as good as a caring surgeon. That's kind of my shtick. All righty. Let's see. I had 2 C-sections and umbilical hernia surgery with mesh. I also have a diastasis recti. Can my diastasis ever go away? No, that does not go away without surgery this far out from your operations. You said most of your operations are revisional. What are the most common complications you fixed that were misdiagnosed by previous surgeons? Great question. Yes, most of my operations are revisional. The ones that have had recurrences, it's almost always because of a technical problem. So the surgeon chose too small of a mesh or placed it in too small of a space. What are instead the complications that were correctly diagnosed but other surgeons were unwilling or unable to fix? Another great question. I feel that if a patient has a groin pain after hernia surgery, there's a reluctance to go in there and undo that repair because there's a thought that you could injure the testicle or the groin or the whatever it is, or affect the blood flow to the testicle or injure the nerves. So there's a reluctance. They're like, yeah, your mesh is balled up. Yes, your nerve is entrapped. Yes, it's affecting your sexual function, but I wouldn't touch it. It's a very risky operation. You can die. I hear that a lot. I hear that a lot. Yeah. Let's see, next one. You're one of the few surgeons who have extensive experience in treating ASIA patients. ASIA stands for autoimmune or autoinflammatory syndrome induced by adjuvants. What are the anomalies you typically see in their immunologic studies? Well, not much. So if you look at their rheumatoid or autoimmune labs, always normal. If you look at their inflammatory labs, CRP and ESR, normal. There are some interleukins you can study. Those are not able to be done under normal circumstances or the normal lab. And yeah, it's an enigma. That's why I say it's an enigma. This topic, your comments, the women who had 21 years of pain, you've answered many of my questions. Thank you. You're awesome and greatly appreciated. Thank you. Okay, next question. Will a spinal cord stimulator for lower back issues mask the groin pain from small bilateral inguinal hernias? Depends on the level. So most groin pain is L1, L2, And most people with spinal cord stimulators are L5, S1, or L4, L5. So usually not. Yeah. Wow, that was me. Few markers of inflammation. That's right. It's not common to see the inflammation. Do you think tensor fasciae lata flap surgery could be a good solution for recurrence after mesh removal for people who have systemic mesh reactions? Okay, let me tell you. Tensor fasciae lata flap surgery, or TFL, is a major and very deforming operation. You're basically using your own body's tissue as a biologic mesh. It's still a mesh, but it's your own body's mesh. But you're moving it from one part of the body to another, so you're going to have a huge scar on your thigh. You're also, which will give you chronic pain, many people have, and sometimes a nerve is injured in doing so. And the recurrence rate with that is about the same as any other biologic mesh, which is in the 30 to 40% risk. So you're now undergoing a huge operation with like more than one out of 3 chance of it falling apart. I'm not a fan of TFL. I only use it in patients that are like really end stage. There are a lot of other options you can do besides that. Okay. Does nylon sutures dissolve over time like silk even though it is permanent? No, it does not. If you sew the midsection, would you have to worry about tearing the muscles because of nylon? Anytime you sew, you're at risk of tearing. That's why we prefer not to sew things tightly, because the sutures almost never tear. It's almost always the muscle tissue that tears. I have chronic cough. Oh, because of a long microbacterial infection for more than 3 years. I have 2 inguinal hernias. The doctors say the hernia will come back because of the cough. I have a quite miserable quality of life with both hernias popping up every time I cough. New doctor wants to operate placing mesh. I would like to know your suggestion. Yes. So there are patients that have risk factors for hernias recurring, just baseline, and it's untreatable. Let's say you have bad asthma and you're coughing, or you have this chronic cough that no one's been able to address, or you have straining, you have no colon, so you have to strain to empty your bladder. There are a handful of patients that have problems that will exacerbate the hernia, and you just have to work around. Opera singer. If you're going to operate on a professional opera singer or a trumpet player or a tuba player, those patients are constantly, you can't say, yeah, I'll fix your hernia, but you can't play the tuba anymore. You have to, drop out of the Metropolitan Opera. No, can't do that. So in those patients, you change your technique to accommodate for this increased risk in recurrence. So for example, I'll give you an example. So for yours, if you have hernias, I would use an extra large mesh, not the typical mesh, so that there's even wider overlap, giving you extra support. I would use tacking and fixation and not just lay the mesh in, so that it's kind of socked in place and doesn't move and doesn't get pushed into your hernia. So there are options, definitely are options. Are some people just so prone to hernias that their tissues cannot be repaired without mesh? Yes. I was told mesh is needed for my hernia, even though no imaging was ordered to measure my hernia, and it's guessed to be large enough to need mesh. Okay, depends on where the hernia is and how big your hernia is and what type of hernia you have and what your risk factors are. So for example, if you have a connective tissue disorder like Ehlers-Danlos syndrome, you have to have mesh. You cannot have tissue repair, period. So that's kind of where the evidence goes in. But you should get imaging. Why not? More imaging and more studies, the better. So beside yourself, who else would you recommend that specializes in hernias that you believe has a high skill level, high success rate in California or Southern California? So go to HerniaTalk.com, which is where this Hernia Talk Live Q&A arose from. And there are plenty of surgeons that I think are great and that we've talked about on HerniaTalk.com. And also, just look at the people that I endorse, so to speak, on these Q&As. This is like, I think, our 61st or 62nd episode. So there's plenty of surgeons that I've talked to that are great surgeons. And, you know, those are some good resources. Have patients successfully tolerated biologic mesh after having biosynthetic mesh reactions? Yes, but I have had patients that have had allergic reactions to Stratus and to Phasix and to Ovitex. So it's not 100%. Very, very low risk though. Biologics in general have very, very low risk. Is the systemic blood test you're talking about called IL-6? Yes, one of them is called IL-6. There's many ILs, interleukins. Okay, a couple more and then I'll let you guys go. Do you encounter macroscopic evidence of mesh illness during your surgeries? No, I usually do not. Every so often I will see like a lot of edema where the mesh is, which is not normal many years after surgery. But in general, when we take out mesh for a mesh reaction, we don't see anything. It's more of it's not even microscopic. We've looked at the pathology, and no one that I've studied who's had their mesh removed had any difference in their pathology than someone that had their mesh removed for not a reaction. This is my first HerniaTalk live I'm watching, so I have to catch up and watch those. Yes, you do. And then you'll be a fan forever. What is it in Asia patients where the relationship between inflammation and mesh and the mind fog comes into play? Many of them report mind fog. Yes, so we don't know, but there's one study that has been published that correlated brain fog as actually due to total body inflammation. So it's not just from mesh, but any type of inflammation in the body can induce brain fog. And that's kind of where that correlation is, I think. I think that's what it is. Dr. Towfigh and guests do a fantastic job getting everyone's questions and hitting the subject matter head on. Thank you. And you know what? I like that you say head on, because many times I feel we doctors are kind of told, don't make a decision for the patient and like just give them all the data and have them make the decision. That's great. However, some of us, and I fall prey to that too, I feel like I give you my 2 cents. Like I would recommend this more than that, like choice A more than choice B, but you can make your decision. I'm okay doing choice B, but here's why I recommend choice A. Some surgeons, actually many surgeons, say choice A or B. You figure it out. And they kind of refuse to get involved in the patient's decision process, which is totally okay. In fact, that's what we kind of teach in medical school, but I feel that often patients do need some guidance. And so I do provide guidance, but it also means that I'm inserting my own biases into your decision-making. So I don't want to be like a pushy doctor for any specific procedure, for example, but yeah, thank you for telling me. I do try and hit subjects head on and not kind of dance around. I have so many patients that come in and say, you know, I went to Dr. So-and-so, I came out, I have no idea what the plan is. Like we talked about the hernia, have no idea what I'm supposed to do. Am I supposed to go for surgery, not surgery, which surgery? How do I treat the pain? Like, have no idea. And I've been in that situation myself for like my family. So thank you to all of you who appreciate that and are not haters. Thank you for that. Thank you for taking the time out of your life to bless us with your insight and wisdom. Thank you so much. And I'm glad to see that you're training surgeons. Yes, in fact, I can't show it to you, but over there in my office is a whole set of goodies for our new incoming surgical interns at Cedars-Sinai. They're amazing. Every year is even more amazing, and I'm super excited that I get to work with them. I often don't get to operate with them until they're in the 3rd year, because the service that I work at, which is the minimally invasive surgery service, tends to have more complicated patients. But I like to stimulate them with a little bit of hernia stuff in their first year, so they are encouraged to do some of that. So I'm super excited that we have a whole new class of interns that just started, I think last week, and you know, they're doing a great job of taking care of my patients and being educated. And if you were able to look over there, you would see some goodies and packages that I made for them, which I will deliver to them on Thursday. On that note, thanks everyone for joining me. Another Hernia Talk live Q&A. I hope you all have a nice summer break. I will see you later, and we'll have more great guests for the rest of the year. And thanks for everyone for following me on HerniaDoc on Twitter, at HerniaDoc on Twitter and Instagram, at Dr. Towfigh on Facebook, and watch for all the episodes on my YouTube channel. So those of you that have missed it, go watch it on YouTube. I do a nice job of like making sure that everything's done well for you. Bye, everyone.